to The Silent Epidemic by Omnia Therapy. I'm your host, Hatice Mehmet-Quirk. Today I'm joined by Natasha Williams, a psychiatric nurse with over 25 years of experience in mental health. Her career spans NHS and private services, including leadership roles and specialist work in addiction and eating disorders. She's particularly known for her ability to build trust quickly and support individuals and families through crisis. Natasha, welcome to the show. Let's start by going back to the beginning of your journey into mental health nursing.
Hi, thank you for having me.
No, thank you.
I think I actually started my career as I was a learning disability nurse.
Right.
So I, from school, was very interested in kind of looking after people, kind of caring. I volunteered at a primary school looking after a little boy with autism.
Nice.
And then I did some work in what was called adult recreational centres. They were kind of like for people with learning disabilities. And I volunteered there, and a learning disability nurse came in one day, and I just was like, that's what I want to do.
Nice.
So I went to Bristol to do my training, and I did that for about 10 years. And towards the end of those 10 years, I was actually working in group homes with people that they called challenging behaviour, which was a dual diagnosis of mental health and learning disabilities. And so that kind of prompted my kind of, me looking into mental health nursing. I went back to university and I could convert in a year because I'd already done 3 years training, and went into the mental health nursing sector.
Right. So really, in a way, you've been in the industry for long enough to really see the development, even your choice of language there. You can see the change from where it was when you first started to where it is now.
It was actually called mental handicap nursing.
Right.
Yeah, and I lived in the grounds, in student accommodation, in the grounds of what it was the old asylums, like the old big hospitals.
Yeah.
So now learning disability is what it is now. But yeah, the language has definitely changed.
Yeah. What are the biggest changes that you feel that you've seen in treatment over the years?
I think there's so much more awareness now, which I think is a really positive thing. And I think because people feel they're able to talk about it, there's not so much stigma as there used to be. But I think we've moved away from like that medical model of care, and kind of a more holistic approach. But I also think social media's played a part, obviously, as we know. I think it's given people the ability to be able to identify with each other because they're like, oh, I feel like that. That's, that's me. But it's also, as we know, negatively affected young people's mental health. And I think there's more specialist services now. But I think we need to be careful of kind of buzzwords. I think I hear a lot now about kind of trauma-informed care, and actually kind of ultimately in practice, trauma-informed care is about providing an environment that a patient feels emotionally and physically safe. Well, that's what you've kind of, if you work within mental health, that's what you should be doing. Do you know what I mean? And actually none of that has changed over the last nearly 30 years. That's what you do, and I think communication and all of those things. But yes, and I think, there's trends, there's funding, there's lack of funding, they all have kind of, a knock-on effect to what services there are being offered.
Nice. Looking back, did you have a sense of just how complex and demanding this field would be?
I think yes and no. When I first started, I probably just went into it completely naively. Working within the learning disability sector first with very challenging people, I was kind of used to the complexities. So moving into mental health wasn't so much of a shock, if you like. I think over the years that I've worked, I think what stands out is how emotionally draining it is for the people living through the experience and those working alongside it. But it's always felt complex to me,
You started your career in the NHS across a variety of settings. What did those early years teach you about mental health care?
Resilience. And I think that early career in the NHS it just taught me invaluable experience. I was really lucky to work in amazing teams across such a wide, broad spectrum of mental illness. That's really stood me well for the rest of my career. And actually, I've learned so much from those years and carried that with me through to the private sector.
So it sounds like being within those good teams and having that experience really set your foundations of how you wanted to work going forward. It sets a
standard that you kind of, that you follow then forevermore. Because the NHS, for all its faults, the standards, the core standards and beliefs of the NHS is amazing.
Yeah. I suppose it can't help that it's just overrun and there isn't enough money to fund it.
When we were talking about, the changes, the increased demand, causes services to be stretched. Increased awareness, increased demand. And then it's kind of a knock-on effect.
Yeah, that's exactly what I was just thinking when you said about increased demand. Well, that's going to come from the increased awareness. More people are talking about it. More people are aware about it.
People are being diagnosed and they want treatment. And actually, I've worked in the NHS through different governments. So there was a period where I worked where Labour were in government and they threw money at mental health services. It was a wonderful time to work in that sector. Because you could offer services, you had things to offer people, and then that all just changed. It all dried up.
Yeah, and how difficult to be able to go from that position where you can offer the service that person needs to help support them, to go to a position where you say, well,
we can't
help you.
And actually, even when I moved up to London in 2010, I worked in the NHS here in Westminster for a few years. And it actually depended on what borough you lived in as well as to what services you could get. Yeah. So in Westminster, you could get a lot more than in Brent. I would take calls for, and I'm trying to say to people needed psychology. They're like, we don't have a psychologist here.
Wow. Yeah.
You were like, oh, okay.
Yeah. How?
What am I going to offer them there?
Yeah.
How? Yes. There's lots of inequalities, I think. Yeah. And even worse now.
Yeah. Someone was telling me the other day that an area in Essex have just all of a sudden said that they're going to cut 50% of the psychiatric care team.
Really?
And she said, she asked the lady, so is there not much of a demand? And she said, there's a 5-year waiting list. A 5-year waiting list. And the team has now been cut by 50%. Yeah. So straight away, that waiting list is going to increase to 8 years.
Of course it is. And actually, I know for an adult ADHD assessment, it's about 3 to 5 year wait just for an assessment.
Yeah.
The services are saturated.
Yeah.
And there's no money. There's no extra money to kind of, match the demand.
And then I think with that comes, it's all fair and well being patient and waiting for a diagnosis, but it's what the person is experiencing as they're waiting, because...
Well, things don't get better either. Often it's opposite and they get worse. So I think that's when it affects the whole system, because then it affects crisis teams. Because all of a sudden people that aren't being able to access their treatment early enough then end up in crisis. And the crisis teams haven't got capacity to take on extra.
And I also think that once someone gets to that point of crisis, it's really, really difficult for them to find that hope and dig in to work backwards to get to that place again.
Yeah, and actually we as a company have had, because obviously we're private, most of our clientele are self-funding. I've had quite a number of people contact me via the website who have been waiting a long time in the NHS for services and are at crisis point, but they cannot afford private services either. Yeah. And so it's a really, really difficult. And actually recently a lot of my time has been spent actually trying to access them, the NHS services that they need. But nobody really wants to know. Yeah. It's always somebody else, another team or, and it's you're so many brick walls and these people are falling through the net.
And the brick walls, you fall in through the net, and you're talking about vulnerable people that are struggling. So even getting up in a simple task like brushing their teeth is a challenge. So how are they meant to be knocking on doors, trying to bring these brick walls down to get them the support that they need? Well, they're not going to. They're just going to keep deteriorating.
And actually, inpatient now, there's such a high threshold for admission that, even that. So there's very, very unwell people in the community without support.
Yeah. And then it's the knock-on effect on their family members and their loved ones that may have to give up time at work to help support and look after that person.
And then they may lose their job.
Yeah.
There's so many factors involved in it. Even the person with the mental illness, they might not be able to go back to work.
It's tough. How did working on the front line shape your understanding of patients, families, and the whole system?
I love working on the front line. In fact, I actually think working on the front line is a privilege.
Yeah.
I think going into people's homes and seeing for yourself with your own eyes what's going on for that person, I think is actually vital in the work that we do. I think it's the kind of, we've always said that a person's environment is like a window into their mind. And actually, as you know, within mental health, it's often not what somebody says, it's actually what they don't say. So you're walking into someone's home, you can, the way that they present, the way that they turn up, how they're living, and you get to see them within, how they, they interact in their everyday lives, how they interact with, families and systems. And actually, I still work on the front line with the work I do. I think it's so important. And to actually lead from the front and actually to be in there yourself to see, what actually is
the full effect.
Yeah, the full effect. Yeah, not just, sitting with a pen and paper and ask, it's, and actually you can get so much more sometimes out of people just being with them, just going to the shops or, helping them with menial practical tasks or whatever. And in fact, back in the day when I was training to do my mental health degree, a lot of the good work on the wards, I had a placement on a ward, was actually done in the smoking room. Do you know what I mean? Because your patients could smoke in the and actually, because you were just chatting.
Easy,
There wasn't that kind of pressure on people.
It took that barrier away.
It was informal. It wasn't so formalised.
Yeah. Interesting.
Not allowed to smoke in hospitals.
No. Definitely. You're not even allowed to smoke outside the hospital now. No. You went on to specialise as a community psychiatric nurse. How does community-based work differ from inpatient settings in terms of challenges and impact?
Well, I'd actually never worked as an inpatient nurse.
Right.
Because I'd started off in learning disability and I'd already worked for 10 years. And that was all community-based. Once the hospitals were shut down, that was all community-based. So I actually kind of went straight from community to community. And I'm actually quite glad about that because I would go and visit patients on the wards with ward rounds and just visiting them. And I could see what an incredibly challenging environment it is for those admitted and those working in it. But obviously a necessary if you like, because people, if they can't be looked after safely in the community, then there is no other option. And I think inpatient, it's very, very difficult. I think because a lot of the time they're not really willing to go to hospital. A lot of them, their rights are taken away, or they'll go voluntary. But if you don't
there's
go,
a reluctance
then and I think that's very difficult to build that kind of therapeutic relationship in that kind of environment. I think there's high staff turnover. It's hard to retain staff. But, it's difficult. And like I said, you've got now wards full of people who are so unwell. It must be very, very hard. And I think in the community, we just get far more kind of flexibility and autonomy in what we do. And we get the nice bits of what I said, of going in and seeing people in their own homes. But obviously that we're lone working a lot of the time, so that, you know, your risks increase.
Yeah. And that sounds like a lot of pressure as well, being on your own, mitigating that risk.
Yeah, I think, you know, I remember when I used to do kind of as a CPN in the NHS, I'd do my last visit, say on a Friday afternoon, and you didn't really tell anyone where you were going or what you were doing. Nobody checked out whether you'd left the place okay.
Yeah. So no one would know until Monday morning.
If something had happened to you. No. And I suppose we're very, very, you know, obviously now we've got the ability to actually be able to really, really make sure we know where the staff in at all times, that they text when they get there, everything like that. Because lone working is, it's really hard. It's really complex and it's risky.
Transitioning into a leadership role changes perspective. What did you learn about managing risk, people and services as a team manager?
Oh my gosh. Do you know what? One of my favourite jobs was actually being a team manager of a community mental health team in Bristol, Supermare. That team they were just amazing, and I loved that role. And actually, I think I loved it because I actually had the ability to kind of change systems within our team, which was increase better outcomes, but it made life so much, you know, obviously it was more complicated in as much that you were then not just managing your own caseload, you're managing staff, their expectations, you know, higher up management expectations, you know, risk, lots of people's risks, you know, their caseloads risk, as well as your own budgets, resources, performance management, key performance indicators, targets, complaints. People would make a lot of complaints, which you'd have to, you know, respond to. And actually just managing the welfare of your staff is a job in itself. Because as we know, it's a very demanding job. And actually some people, the staff themselves have not very well. And need kind of support too. It's very common within mental health.
That leads me nicely into my next question, actually, which is, what are some of the pressures that leaders in mental health services face, but not just leaders, you know, anyone that works within the space that people don't see or don't appreciate?
It's a lot of, there's so much pressure, there's so much that goes on behind the scenes. I think especially if you're a team manager or you're a leader, that your level of responsibility to others, especially when things go wrong. And in mental health, things can go wrong because it's unpredictable. And we're in a blame culture as well, aren't we? And you feel that you should have prevented something, you could have done something differently. And you also have to prove that you've done everything correct, you know? And I think that's a big pressure for nurses. And so that's, there's just so much. And, you know, even just when something does, like for a death, for example, and people do die, you know, they don't always die by suicide, sometimes they just pass away. But having the amount of kind of root cause analysis and everything that has to happen to kind of determine that you as team manager, that your staff have done everything possible to make sure, you know, that you couldn't have prevented that death. It's a lot, and that, you know, they're complex. People go into very different, you know, I've been to some awful places in awful situations, and it's a bit like the police, isn't it? The ambulance service, that kind of thing. You know, it does take its toll mentally.
And then it's like you've got that going on in the background, but then you're expected to go out and just do your everyday job anyway, which is already really
with
difficult.
A smile. And then go home and look after your family.
And smile.
And talk about nonsense. Exactly. It's hard going. And I think that's probably why with the NHS, because the pensions was always really, really good, and people could retire at 55. And I think by 55, people are like, I'm out of here. You know, I've done my time.
Because that is such a high level of pressure to be managing. And I suppose there is only so long you can do it for without it having a detrimental effect on yourself.
Well, and also without you almost kind of becoming so care fatigued that you don't care anymore. And I think that's what happens with burnout. You know, we can burn out so quickly and become so care fatigued, and that's not good for you or the person that you're looking after.
No. You know, I think that's the most important bit, is remembering that if you do get to that point, you're not doing anything right by yourself or them. And actually, it's a massive risk.
It's not commendable to push through.
I mean? You can't soldier through.
No.
You can't. I mean, I've said it to you, like before we came on the camera. I had this thing before I came into this, it'll be all right, or never had a sick day or anything like you. I don't have that luxury in this job. If I don't feel 100%, I can't do my job, because if I do, I could potentially be putting my client at risk or miss something that could cause harm.
Exactly, and then you've got to then deal with the repercussions of that. I also think we work with people that are quite, highly anxious. They're hyper vigilant, and actually they can pick up when you're not yourself. They know instantly when you walk through as I know when I walk through the door, what kind of day I may be going to have. They also know kind of how you're going to be too.
Yeah.
So you have to protect yourself.
Yeah, I've never really looked at it from that hypervigilance side of, they're going to be picking, obviously you know about transference and all of that, it comes in.
You're both transferring.
A
lot of the time I'm trying to bat away a lot of transference and this kind of projection. But also, I work with someone who's very, very good at knowing what kind of mood I'm in. And we'll always, and we'll say, "You okay? You seem a bit." Hang on a minute, that's my job.
Wrong way.
But
So you moved into the private mental health services in London. What differences did you notice between NHS and private care, both clinically and operationally?
So I moved when I worked in Westminster in the NHS for a few years, and actually when I was saying about funding and changes to systems, our caseloads increased, funding was less, more and more paperwork, and actually I had more people to look after and hardly any time to actually see them or do anything. And it started to feel really unsafe to me, and you do your Monday to Friday, and then I'd literally go home on a Friday and think, I guess are they still going to be here on Monday? It was a real. I didn't like it. And there was nothing really you could do about it, because that was the way that the system was.
It sounds like you're almost tasked with doing a job that you couldn't do.
No, a job and also, but having kind of gone through that whole periods of where you could, to then suddenly not be able to, and it was So I had an opportunity to move into the private sector, and so I kind of took it. And actually, it's a bit of a leap because. Again, that kind of NHS pension, that security of the NHS, that's the one thing you do get is security. You can, you get paid when you take days off sick or your holiday, all that holiday time. And so it was a big jump, but I'm glad I did it. And I suppose the one thing that I'd kind of run from was the one thing that ultimately I didn't have to worry about, which was funding. You go into the private sector and funding isn't really an issue. You can give people opportunity. You can give them time. You've got time to reflect on the work that you do rather than just do it.
Do it. Boom, 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 boom. Yeah.
But also, I think, having worked in the mental private care for some time now, I think I can also see the problems that wealth cause. Because sometimes it causes more problems than it actually solves, or actually is the root cause of the problem. So I think, it's a double-edged sword, really. But operationally, it's I suppose it's much easier when you've kind of, you've got resources and you can access whatever you need. But then it comes with other complexities too. There's often very, very difficult, complex family dynamics. They may not have to worry about where they're going to get the money to pay for their rent or their food or their heating, but there's lots of other things that kind of can cause real issues too.
And then I suppose comes into question, the thing that came to my mind there was, I suppose with the NHS you sometimes get clients where they get to the point, or patients where they get to the point where they know they need it and they know it's the only chance they're going to get at getting themselves well. But then when you flip it on the other side, where it's just like, I can afford this and I can afford that and I can afford this. there's that desire issue, isn't there? Because then there's that
exactly.
need, because mental
that
health,
almost life or death.
Yeah.
Do you know what I mean?
Yeah.
And actually rock bottoms are suddenly very different.
Yeah.
You know, because I don't know, you lose your license because you got caught drink driving. You've got a driver. That doesn't, you know, somebody that doesn't have that access to that, they might need their car to actually sustain their job. Without a job, they can't pay for their mortgage, their rent.
Yeah.
And actually, rock bottoms are very, very different. And actually reach very much quicker.
Yeah. Yeah, and I suppose that complexity of managing all of that can make it more desirable to seek that change than just having all the solutions available to you.
Don't really need to change that much because it's not actually affecting my life so much that I'm forced into kind of changing. You know?
You've worked extensively with addiction and eating disorders, both of which can be incredibly complex. What makes these conditions particularly challenging to treat?
I think, they are very complex conditions. And I think with both of them, they are a complex relationship between behaviour, coping and identity. We know in eating disorders that it's not about the food on the plate. We know that in addictions, it's not about the drug of choice. And I think these behaviours, these have become such inherent long-standing coping mechanisms that they're really difficult to shift. They're really difficult to change. I think there's a real ambivalence to change with it because it's become someone's safety net. It's their crutch. It's their go-to. It is very, very complex.
What do people often misunderstand about these struggles?
I think they misunderstand that this isn't a choice for people, that they're not choosing this. You know, just eat a bit more. Just stop drinking. You know,
don't have the first one and you'll be all right. Or just have one.
It's just because I think people think recovery sometimes is a very, very quick process, and it's not. It's a very lengthy, long. You know, it takes a long time, and it's not linear. And I think people are on a journey. And that journey sometimes forward, but sometimes it actually goes back. Yeah,
and you've got to work at it every day. It's not that you do a treatment plan and it's done and it's finished. You're working at it daily to sustain it.
Exactly, and I think that is the kind of the similarities between those two conditions. Is it's a lifelong struggle. It's a lifelong daily commitment. To not doing that behaviour, to not, because it becomes, like I said, almost like your inherent identity. It becomes who you are. Very difficult.
And I suppose with that lack of understanding comes a lack of empathy or sympathy for people in that position, and the stigma and, you know, all of that stuff.
And I think, and it does, especially with family dynamics. So I think with addictions and eating disorders, I think because they can go on for quite a long time as well, if there's not that really good early intervention, that ultimately it wears the person down, and it wears the families down, and their empathy almost runs out. I've seen it time and time again. They can't keep doing it. Do you know what I mean? It's very draining for all.
I suppose the person's hit the rock bottom, but so have the family in terms they've got nothing left in the tank to give.
To support, to empathise, like you say. Or because often, especially there's an ambivalence about change as well, often we find that the families are far more wanting the change than the actual person. And until they can do it, they want it.
But then sometimes you can go the other way around as well, in that when that person starts to change, the family have to catch up to that change, and they become quite uncomfortable with the changes that they're seeing. So they have to go through their own process to meet that change.
And sometimes they're not willing to do that. And actually, a lot of the time, the problems within that family is actually the underlying reason for the behaviours in the first place. And if that person's willing to change and they make those changes, without those changes over there, you're going to literally slip back into those old ways because it's a systemic problem.
Yeah, of course. And like, I come across it a lot where, for example, someone might go onto the program and then, you know, the family members, and they say you recommendation of everyone having therapy because it's something everyone needs to heal from. And then the feedback that you get a lot is, well, no, why should I have to do it? Because it's not my problem. Yeah, or I've suffered enough and I've given enough of my, and it's like, well, actually it will give you the tools to work it through, understand it, heal from it, process the pain and difficulty that you've been through, and together find that way forward on this new path that's been set. But, you know,
and actually, a lot of the time, the families are also quite unwell. We've had that. It's usually, like, you know, as we know, it doesn't start with you. It's it often
goes back.
It's generational stuff. So, and they haven't, and especially kind of, and me and a therapist were talking the other day about this kind of, again, around the wealth thing, around third generation wealth, and how kind of it seems to really affect you've got the person that's made all this money, and they're just about, they've made their money, they kind of pass it on, and it becomes this kind of almost like this ticking time bomb. And then by the third generation, people, they don't have to work. They don't know the value of anything, they don't know the value of money. Plus, they've probably not really been parented. You know what I mean? They've been parented by other nannies, and it kind of becomes this thing where it started kind of back here, but you're only really concentrating on of this person here, but there's just, you've got to go.
There's a lot to go back.
There's a lot to go back.
And then I suppose it's really difficult because if you've got someone who's not working, doesn't have to work, because can access everything that they've got, where's their purpose? That's it. And actually that's what I think I talk to my patients like that, and I think that's what is missing is that purpose, is that structure and that purpose, which is kind of what we get out of bed for, isn't it? You know? And not to say that work is our only purpose, but it's a good, it's a good part of the foundation for the get up and why we do what we do and why we get up and all of that.
But there's so many other things that we also have purpose for too. But those often aren't there.
And then, as you said, if that's not been modelled or that's not been taught or there's not, it's so complex, isn't it?
It is. And I think sometimes a lot of the eating disorders, especially anorexia, it's almost like look at me, please can you see me, please can you hear me, you know, and until I get really, 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 really unwell, no one notices.
Natasha, thank you for sharing your experience and insight from your experience in the industry. Your perspective highlights not only the complexity of the work, but also the importance of compassion, trust, and consistency in supporting people through some of their most difficult moments. Before we close, what final message would you like to share, whether to those working in mental health or those currently navigating their own challenges?
I think the message I would like to say is to kind of have hope. I think the one thing that I've always tried to instill in people is there is hope. It can change, it can get better. I think for those working within it, I think you need to take care of yourselves. You need, first and foremost, if you can't look after yourself, you can't look after anyone else. And I think it's really important to have that downtime, that supervision, the support of your friends, your family, that decompression, that time away from work. Because I think it's really important to have, to balance out your life so that it's not just all about work, that there are other things, that are just as important.
To our audience, thank you for joining us on The Silent Epidemic. If this conversation resonated with you, please like, share and subscribe. Join us next time as we continue exploring the reality shaping mental health care and recovery.